Hi, thank you, Patrick. Good morning, everyone. The topic I have is preserving circuit patency. As we know, this is also use the words filter life or filter run time or time before clotting, and this is important because it's intended to be a continuous therapy, and we're hoping that we can do things to ensure that we get the adequate dose and adequate treatment from this. And I'm not going to talk about anticoagulation. I think what I've got to present will complement what Professor Ritchie has just said, and also our next speaker, and I think will provide some interesting points of view for you. And if it makes you feel a little better, I've got a lot of pictures, so you'll find this maybe of a good, sort of clinical perspective. The science is difficult because, we all, and myself included, do a lot of small studies. Whenever you're asking a question about filter patency or life, and your main intervention in a study or an experimental design is influenced by so many other covariants, which you have to try and control for some of them, but many of them you can't. And they, of course, have an effect on circuit patency as well. So just to begin, we understand the membrane structure, but I'm just highlighting to you that when we do get failure, it's a clotting and a plugging or a clogging process. And this is a little bit of work I did many years ago, which is entitled the membrane autopsy. So you can see at the entry point into the membrane there is clot collecting there, obstructing the forward flow, and there may not be any significant clotting down into the membrane further, but there is certainly a clogging process. And the other problem in the extracorporeal circuit is the bubble trap, or where there's a gas-blood interface and we get clotting occurring there. And I have some evidence that this can be in up to 85% of circuits. There's some degree of clotting there. The frustrating thing is that if this clotting is terminal, the forward flow of blood is blocked completely, and in fact the membrane may be not the thing that's clotted. It's actually the chamber itself that is the problem. So we understand that these are the 2 points of the circuit really where this problem exists. This is my sort of approach to what I might say is the sort of traffic lights. People ask me the question, well, what's considered reasonable, or the benchmark. Zacharias just talked about the fact, around 24 hours is true. I've said, if you're getting between 20 and 30 hours continuous function, you're doing pretty well, and you're in the green zone. But it's when you have, between 0 and 8 hours and frequent episodes of clotting there, and sometimes despite everything you do, including the use of citrate, I've seen, you do have problems not only with lack of treatment and dose, it's expensive, it's time, and the patient is exposed to a lot of circuit changes. Just for interest, I collect data, and I think it's a good thing we should all do. And this is about 8 years of data that I published back some time ago, showing that we do have in my ICU a mean filter life, and we use the mean because of the size of the data pool of around 20 hours. And when you look at the large randomised controlled trials done on dose across the globe, 14,000 circuits of data, the mean circuit life was around 24 hours. So there's a sort of a good benchmark to compare to. I've circled 12.6 because that was a year which leads me to talk to you a bit about my next point about the system we work in and people and our teams. We got a fleet of new machines that year. And with the new machines, it just reflects that there's a lot of training and education until you start to get your use of the machines, and it does affect your filter life despite all other problems. But we do have our successes, and here's a circuit showing that it's still functioning after 91 hours. But the question is this the right thing to do? How long is too long? what's happening if blood is still in a circuit after 91 hours. I'm not sure. Just for your amusement, Patrick talked about some of my background. I did have this idea in working with Ronaldo in Australia to run a circuit which had 2 filters on it. So you had one running and one not running, and when one clotted, you just simply undid the clamps and allowed the other one to work, and then clamped the old one off, and then you changed it. So you could keep the therapy continuous. You can see it's called the sort of twin filters, and there's a couple of pictures there to show you. We didn't progress it very far. I couldn't get the ethics approval for that, but we did do some initial work, just for your interest. So here's my sort of key point, and this is where I'll really divide the presentation into what I'm talking about, the system we work in, and then some issues related to the circuit. And the system is really dealing with who you are, how many patients you treat per year, what the size of your department is, how many nurses you've got, whether you've got people that are dedicated specifically to, champion the cause for this treatment amongst many other things in the ICU, and also the issues of how you, audit and look at what you do. And that brings me to sort of this notion of the multidisciplinary team, which includes many people and people outside the ICU, but you do need some people who are the leaders, and this picture just represents there are many teams which are championing the cause to become those committed to this, and in fact implementing your policy and procedures correctly so things are done safely and well. It does involve a lot of teaching, and these days simulation and so forth. So many things are complementing this. For example, prescribing sheets, checklists that are done for nurses shift by shift to make sure that things are as prescribed correctly. There's correct communication lines occurring, and we're really, as I'm in Italy, I highlight the Ferrari team trying to do things to a standard that is very high. So that's my point about the fact that, independent of many things, including even, I could say, some of your anticoagulation policies, and mine for that matter, the system is really important, and to get those things working well. Okay, so what about the circuit? And this is where I'll just, finish the rest of my talk talking about some of these points. And Professor Ritchie's really given me a good lead into some of these things, and these are the things I'll quickly talk about. I mean, femoral access is something that's difficult to avoid, because when our patients in the ICU may have devices and lines in the jugular vein, then more junior trainees are the ones often after hours inserting the line, so the right femoral vein is easiest to use. And certainly when, again, you look at a large study where you can get data just to see what was happening. This is the renal study, which was the Australian dose trial published in the New England Journal, over 1,500 patients. It was the right femoral vein which was used the most, probably just because of the convenience of it, and as I've said, the way it works where other lines may already be in place. The filter life or runtime, right femoral versus left femoral, you can see the data showed in this study that we published with Kim and Bayoung back in 2011, showed that the right femoral, in fact, was favouring a longer filter life. You can see there, and here's the Kaplan-Meier graph for that, and 341 circuits. So I think it's reasonable, although a single centre retrospective design study was a reasonable thing to conclude that. There's been other work, and Nigel Feely, who works with me, we did a survey of clinicians in our Australasian context, and noted that, again, people are really using the right or left femoral vein for access, and data from another study done in Australia at a larger hospital in Melbourne, 131 patients with 192 access catheters, and over nearly 900 circuits, showed that, including the data here for ECMO and tunnel devices, it was the femoral, and in fact, this graph showing the runtime or the filter life by site, it was the left femoral, which was more favourable compared to, the right femoral more favourable compared to the left. So I think the femoral site's the one that most people use by convenience, and has got some good evidence that it's the right thing to do. Just one other study to throw in, which is another study from the west coast of Australia by David Morgan. He and his group, they randomised people to either have the catheter, which was a jugular device inserted at full distance into the right atrium. They placed, it's a soft tip catheter, right into the RA, or the opposing group was a shorter catheter, which was further up the superior vein. And, there was clearly that pathway to the study. And what they found was when the catheter was passed further into the right atrium, it did favour filter life in terms of what they call dialyzer lifespan, was a primary outcome, 24 versus 17.5 hours, and that was significant. So I think those sort of factors for access do favour, a longer catheter being passed through to the right atrium, or pretty close to it, if not in. Access catheters vary in their profile, and here we see the design of the way they're built. It's my opinion and view that the side-by-side or the double D profile is a better performing catheter than the coaxial design. We did some work on this some years ago, and some in vitro work with a lab design, and I'm just showing you a graph here of the negative pressure that's created on what we call the arterial limb, or the outflow, drawing the blood from the patient through the red lumen, as it's often coloured. And you can see this is a Prisma circuit at the time. The red bar shows that as the blood pump speed is increased, the faster you pump the blood, the more negative pressure there is, and raises the question, when you then connect the circuit to a catheter and then you put the catheter in the patient, and whichever body side it's in, your negative pressure will only become more negative. And negative pressure, I believe, beyond about minus 50 millimetres of mercury, when it gets to more than minus 100, this in itself starts to cause what's called silent or covert flow reduction, and it's something that you can be unaware of. So I'll just briefly mention that. This is the Bard Niagara catheter we use, which is a double D side-by-side sort of profile. Dolphin is another one, which is distributed, I probably think, by Baxter now, or Gambro. It was Dolphin Protect, also a nice catheter design, and that's the double barrel. So when you connect the device to the circuit and the circuit's running, as I say, it's creating a negative pressure in the system, and this brings about the notion of mechanical failure or flow failure. And this is a study we did, published in Blood Purification in 2010, and just raised the question or the observation that if you see down there in 160 circuits, why is it that one circuit can maybe function for 38.5 hours? You're seeing, I'm trying to show you the one on the left-hand side there. Circuit 1, 34 hours, all good. Circuit 2, 38.5. So why is it the next one goes for 14 hours, just when nothing's changed? So you can see that there's this disparity between, in fact, the last two bars on the histogram there, one circuit running for 6.5 hours, 9 hours, and nothing's changed, and the next one goes for 77 hours. It's hard to explain unless you consider that there may be obstructive flow in the circuit, and this is the cause of it. It's mechanical failure, as we term it. So Ling Zhang from China and I did some further work on this with looking at pressures, and this is the sort of thing you see on the screens of the modern machines now, quite easily displayed. We understand, the colours there represent, as I've indicated, a circuit beginning a treatment, and the negative pressure, say minus 50, and it's minus 50 in this graph up to 36 hours and beyond. So this is one that you'd look at the bedside and you'd see the pressure with the blood pump speed you're running, and the blood pump speed here I believe was 200 mils per minute, and you know, the venous pressure is also in the positive range as it should be, the blue graph there, and the only thing that's really changing is the gold colour, which is the transmembrane pressure, reflecting that there's a slow and progressive clotting or clogging process occurring. But this is at 36 hours, if this is circuit terminated, you'd think, yep, that's all good, and reflects very good function, access, etc. This is something you don't want to see. And of course, this shows in 4 hours that there were in the red zone there, the red graph, some episodes of significant negative pressure related to something related to the connection of the circuit and the catheter to the patient and their access site. And then there's a terminal event where the transmembrane pressure skyrockets very high and the whole circuit is considered, and the nurse would report it, that it's failed, it's clotted, it's stopped. So they're the ones that we have concern about. And you know, this is my schematic, but on figure A here, I'm just showing you as the blood pump speed is increased up to what you might call, you know, altitude cruising speed at 200 mils a minute, and that's where you're leaving it as prescribed. That's the sort of negative pressure you get. But figure B shows where the access has failed, and there's a lot of negative pressure in the circuit, and this is this flow reduction, which can be related to the machine alarming negative pressure, and that's true. But this is something that published many years ago now, but it just highlights this is a flow measurement across the circuit, a Doppler flow, and you can see there there is a systolic and a diastolic component to it, but there is a point there about a third of the way through where there's been some change of the patient's position in the bed or an intervention. There's been some negative pressure. It to some degree has resolved, but then the flow has continued to be the negative going forward and the filter clots. So this is a mechanical failure problem, and leads people to then the next point to say, well, how fast should you pump the blood? Because this negative pressure of, I'm suggesting around minus 50s as far as you should go. You know, the faster you pump it, the more negative pressure you'll have. So here's a study which looked at this across an ICU in Australia, and I found that there is an association between blood pump speed when it gets up to more than 200, 250 mils a minute. Filter life is starting to sort of, if you like, not get any better, and it sort of highlights that there's probably a terminal speed there, and that was quite a good evaluation in over 1,300 circuits. So this is where I'm going to conclude and just highlight to you another study we've recently published with my colleague Nigel, and we did a randomised controlled trial comparing blood pump speed at 150 mils a minute, which is what a lot of people use, versus a flow of 250 mils a minute, and this was in 460 circuits and more than 8,000 hours of treatment. And on first circuit analysis, or all circuits, we noted there was no difference in, you know, filter runtime or filter life associated with those two different blood pump speeds, and perhaps makes the comment that you don't need to go faster if you don't need to. 150 mils a minute is where we're now sitting on. So there's the Kaplan-Meier graph for that. So this is where I sort of try and wrap it up in one schematic to say, look, we can't often control for the patient's BMI, the positioning and so forth, but you know, a longer, larger catheter in the right femoral site with a blood flow between 100 and 200 with an arterial pressure of about minus 50. Okay, I think this is the right recipe for, you know, filter patency, and other things like pre-dilution fluids we've heard about, so I won't dwell on that, but they also affect the venous chamber, and when you put fluids in there, the chamber doesn't clot. And we found this in a small study which I looked at the idea of vertical flow versus horizontal flow. But what we noticed in this study was that, there is no benefit in vertical or horizontal flow, but we did notice that the post-dilution fluids and the blood and the fluid do separate very nicely in the air chamber, and this in itself, and you can't easily see the fluid there, but it's sitting on top of the blood and it stops clotting occurring. And it's not something that's new. Back in 1995 I found this research by Gretz and co-workers that in dialysis they noticed there's this sort of plasma layer, which is good news. So I think put Filter Life on your radar. You need to from somehow get the data from your bedside charts, and when you've got a life of like this one recorded as we do every hour, so our physicians can see this, 59 hours is good news. But when you've got these episodes with lots of downtime, it's not good. And if you audit your data, indicated here by circuit usage, this is the two machines we use, it just gives you some sense of associating the number of patients that you have and the treatment days to then give you a calculation of how many circuits per day you're using, and 1.6 or 1.5 is about 20 to 22 hours. So that sort of matches my comment and my data from over some years. So I think my last slide, thank you, Madam and Mr. Chair. I'll just leave you with these points. The team's really important, our access catheters. We need to recognise mechanical failure and differentiate that from anticoagulant therapy. Pre and post fluids, our bubble trap design and our blood flow rate are really important. So a little speedy finish, but I say thank you very much.